Okay, this is Alexander Eden. I'm a registered nurse at Southeast, and I'm going to do a part 2 assessment video. This is my father-in-law, Terry Murphy. He's going to cooperate and help us get this assessment done today. So, we're going to work on the posterior chest. And if you could just sit up just a little bit. Okay. First, we're going to palpate the chest for tenderness. Okay. Doing some palpation here. Any tenderness?
No.
No. Okay. And then when I get down here to about the 6th intercostal, the costovertebral angle out, I'm going to, can you sit up straight for me? Yeah, thank you. Okay, he has normal expansion. The expansion is good, normal. We're going to do a little bit of percussion. I don't hear any dullness. It's all hollow sounding. Yeah, he's got a good hollow sounding lung set here. Doesn't sound like he's got any gunk in his lungs today. Okay, and then I'm going to also tape for breath sounds and adventitious sounds. Just want to draw attention to the fact we're going down the center for that, and you don't assess over the scapula. Okay. Go ahead and take a deep breath for me. That's good. And another one. That's real good. Another one. Another one. Don't hear any cracks, popple, wheezes, or any other adventitious sounds. Go ahead and give it a breathe. Alright. And again. His lungs are clear bilaterally. I'm almost to the 6th intercostal space near the diaphragmatic border. And I haven't heard a single negative sound yet. Terry, can you go ahead and say 99 for me?
99.
And 99?
99.
Can you say E?
E.
And E?
E.
Okay, and for pectorally, whisper 1, 2, 3.
1, 2, 3.
And 1, 2, 3.
1, 2, 3.
Okay, we're going to come around to the anterior chest. Okay, we're going to palpate for tenderness, sensation, surface masses, or lesions, or fremitus. Surface masses or lesions. No use of accessory muscles in his breathing. 99.
99.
And 99.
99.
99.
99.
99.
99.
And I'm assessing now for tactile fremitus, 99.
99.
Negative for tactile fremitus, 99.
99.
99.
99.
And 99.
99.
And 99.
99.
Okay. We also listened for any adventitious sounds. I didn't hear any. I didn't hear any wheezes, pops, cracks, fine crackles, coarse crackles, anything like that. Okay, let's go ahead and palpate his heart and neck vessels. I'm going to feel there's no both his carotid pulses are normal. There's no bound, there's no thrill. I'm going to also tape for any bruits. Using the bell of the scope. Okay, I hear nothing there. And I hear no bruits there. That's a good thing. I'm going to go ahead and palpate Terry's apical pulse. It's at the right sternal margin, at the left intercostal border. I have an apical heart rate of 82 with a respiratory rate of 20. And I'm looking at the precordium area of his chest near his heart to see if I see any visible thrills or any visible movement. I have no visible thrills there. We did palpate his apical pulse. I'll palpate his apex. Apex, left sternal border. No thrill there or there. Down to the tricuspid and over to the mitral. Okay. I palpated those and now I'm going to listen to them. Same thing. Tricuspid. Sounds like a good rhythm with no audible, no S3s or S4s, or it was normal. Sounds like a normal sinus rhythm. Okay, next we're going to work on the peripheral vascular system. Okay, so if you could stick your arms out for me like this. Okay, I'm inspecting his arms, hands, for any type of size abnormalities. There's no evidence of edema. The skin is warm to the touch. Looks like he's getting full circulation. They're symmetric. The venous pattern is unremarkable. No lesions, no abnormalities in hair distributions. I don't see any edema, and no varicosities in his skin. His ring isn't tight. Okay. We're going to palpate his radial, ulnar, and brachial pulses bilaterally. Ulnar, radial, brachial, all normal. Brachial, radial, ulnar. The patroclear lymph nodes are going to, or the brachial lymph nodes are going to palpate that to see if he's had any swollen lymph nodes going down his arms. And it's 0 millimeters in duration. Same here. The lymph nodes are unremarkable bilaterally. We're going to perform the Allen's test. This will be useful if we were going to get arterial blood gas. So if we were going to stick him for an arterial blood gas, we want to be sure that he had some way of getting blood to his hand, because if we stick him arterially and he doesn't have blood flow on both sides, and we blow this artery, he could lose this hand. So that's why we perform the Allen's test. Arterial blood flow there and there, so we could safely stick him in this right hand. I'll check on the other side too, if we needed to get an ABG if he were hospitalized. Okay, with the Allen's test performed, he's good to go on both sides. Okay, we're going to inspect his legs, feet, and toes for size and symmetry. Just go ahead and put your bare feet up on here. Alright. We're looking at his feet. First of all, we're looking for edema. It doesn't look like he's got some decent vascular return. His feet are unremarkable on both sides. They're symmetric. The venous pattern, he does show some surface spidering bilaterally. His varicosities are limited. He looks like he's getting a decent amount of venous return at this time, but he does have in the below the knee, he does have some spidering, but it's unremarkable and it's similar bilaterally. I don't see any ulcerations or any. There's just nothing here to make me believe that he's not getting decent enough venous return, or if he were at risk for that. No lesions, no discolorations. He still has good, fairly good hair distribution, and I even noticed that he still is picking up hair on his toes, and that's a good sign. He is getting some pretty good distribution of blood to the legs. Okay, and it asked me here to palpate his feet again. And I feel decently warm, decent warmth, not too cold. Any pain? Anything? Okay. And now we're gonna bilaterally we're gonna palpate. You asked me here for femoral popliteal dorsalis pedis and posterior tibialis pulses. So on the right, femoral. Positive for femoral. Popliteal. This would also be known as a soccer player's injury. You get kicked in this artery, you can have a really bad, serious injury pretty quick. Dorsalis pedis. Got a pulse there, and if you were in an institution or whatever and you didn't have a pulse, you would definitely want to get a Doppler to be sure that you're getting this flow, especially on initial assessment. Posterior tibialis. Okay, I've got all four pulses there. I'll go up here again. There's the femoral, popliteal. Good. Dorsalis pedis. which is good. And posterior tibialis. So on my assessment, he has decent, very decent lower leg flow and venous return. And it looks like, as far as assessment 2, that's the end. I'm Alex, this is Terry, thanks.
Thank you.